Bloat refers to the abnormal accumulation of gas, food, or fluid in the stomach, leading to its enlargement. This leads to abdominal distension, discomfort, and pressure on nearby organs such as the diaphragm and major blood vessels. During simple bloat, the stomach is dilated but not twisted. While bloat alone can sometimes be managed medically, it can rapidly progress into GDV. Gastric Dilatation Volvulus, GDV, is a life-threatening emergency in which the stomach not only fills with gas, dilatation, but also twists on its axis, volvulus. This twist traps gas and food inside, cuts off blood supply to the stomach and spleen, and severely impairs circulation to the heart. GDV can lead to shock, tissue death, cardiac arrhythmias, and death within hours if not treated surgically.
Dog breeds most prone to GDV. Highest risk: large, deep-chested breeds. Great Dane, highest risk of all breeds. German Shepherd, Weimaraner, Standard Poodle, Irish Setter, Doberman Pinscher, Saint Bernard, Akita, Rottweiler, Bloodhound. Moderate risk: Labrador Retriever, Golden Retriever, Boxer. Setter breeds: Gordon, English, Belgian Malinois. Important: any breed, even small dogs, can technically develop GDV, but deep-chested large breeds are at greatest risk. GDV equals dilatation plus volvulus, shock plus ischemia, death without surgery. Prophylactic gastropexy is strongly recommended for high-risk breeds, especially Great Danes, when they are young.
Etiology, causes, and risk factors of GDV in dogs. 1. Anatomical factors. Deep, narrow chest conformation. Increased stomach mobility, loose gastric ligaments. Large body size. 2. Feeding and management factors. Eating one large meal per day. Fast eating, gulping air, aerophagia. Feeding from elevated bowls, shown to increase risk in some studies. Dry kibble diets, especially with fat listed in the first 4 ingredients. Drinking large volumes of water right after eating. Exercise immediately before or after meals. 3. Physiologic pathologic factors, behavioral factors. Delayed gastric emptying, abnormal gastric motility, previous episode of bloat, splenic laxity, family history of GDV, anxious, fearful, or highly stressed temperament, advanced age, male sex, slightly higher risk, and thin body condition score.
Pathophysiology of GDV in dogs. Gastric dilatation volvulus, GDV, begins with rapid gastric dilatation as the stomach fills with gas, food, and fluid due to aerophagia, delayed gastric emptying, and fermentation of ingested feed. This sudden accumulation causes severe gastric distension and a sharp rise in intragastric pressure. As the stomach enlarges, it becomes unstable and predisposed to rotation. The distended stomach typically rotates in a clockwise direction along its long axis, leading to volvulus. This rotation occludes the esophagus, preventing vomiting or release of trapped gas, while the pylorus is displaced dorsally and cranially. As a result, gas becomes trapped in the stomach, causing progressive distension and worsening pressure within the abdomen.
Vascular compression and ischemia play a central role in the rapid deterioration seen with GDV. As the stomach twists, it compresses the portal vein and caudal vena cava, leading to a dramatic reduction in venous return to the heart. This results in severe hypotension and the development of combined obstructive and hypovolemic shock. At the same time, the blood supply to the stomach wall and spleen becomes critically compromised, leading to tissue ischemia and necrosis. Splenic involvement is a frequent and serious complication of GDV. Because the spleen is attached to the stomach via the gastrosplenic ligament, it often twists along with the stomach, resulting in splenic congestion, splenic vein thrombosis, and, in severe cases, splenic rupture results in circulatory collapse and blood loss.
In GDV, systemic shock develops from multiple simultaneous mechanisms. These include venous compression from the distended stomach, massive fluid sequestration within the stomach, third spacing of fluids into tissues, and endotoxemia originating from the ischemic gastrointestinal tract. Together, these processes lead to poor tissue perfusion, the development of metabolic acidosis, and progressive multi-organ dysfunction in dogs. Reperfusion injury is a life-threatening consequence that occurs after decompression or surgical correction. When blood flow is suddenly restored to previously ischemic tissues, large amounts of free radicals are released, triggering a powerful systemic inflammatory response. This can progress to disseminated intravascular coagulation, DIC, lead to cardiac arrhythmias.
In the early stages of GDV, within the first minutes to 1 to 2 hours, the clinical signs are often subtle but appear restless and anxious, pacing continuously and showing repeated episodes of unproductive retching, often described as dry heaves. Hypersalivation, excessive drooling, frequent lip licking, rapid swallowing, and mild abdominal discomfort and distension may just begin to appear. As GDV progresses and the stomach continues to enlarge and twist, the classic signs become unmistakable. The abdomen becomes severely distended and feels tight and drum-like on palpation. Dogs continue to strain and retch without producing vomit, while their breathing becomes rapid and labored due to pressure on the diaphragm. The heart rate increases significantly, pulse quality weakens.
GDV is a true surgical emergency. There is no waiting and no watchful monitoring. The priority is rapid stabilization and immediate surgery. Every minute matters because delayed treatment dramatically increases the risk of death. Step 1 is immediate triage and oxygen within the first 5 minutes. The dog is placed on 100% oxygen using a mask, flow-by, or endotracheal tube. Stress and handling are minimized, while rapid assessment of heart rate, breathing rate, mucous membrane color, pulse quality, and mental status is performed. Importantly, treatment should never be delayed to confirm the diagnosis if GDV is strongly suspected. Step 2 is aggressive IV shock therapy. 2 large-bore IV catheters are placed, usually in both cephalic veins, and crystalloid fluids are given at a shock dose.
Step 3 is immediate gastric decompression, and this step must not be delayed. If the patient is stable enough, an orogastric tube is passed to release trapped gas and fluid, followed by gentle, warm water lavage. If the tube cannot pass, trocherization through the side of the abdomen with a 14 to 16 gauge needle is performed. Decompression alone can cause a dramatic improvement in blood pressure. Step 4 is limited emergency diagnostics after stabilization, but never at the expense of surgical timing. A right lateral abdominal X-ray is used to confirm GDV, with the classic double bubble sign being diagnostic. A small database including PCV, total solids, lactate, electrolytes, and blood gas is obtained. A lactate level above 6 millimoles per liter is associated with a worse prognosis.
Step 5 is the immediate start of broad-spectrum intravenous antibiotics. Drugs such as ampicillin or unicin are combined with enrofloxacin or a cephalosporin to protect against septic shock from an ischemic stomach and intestines. Step 6 is emergency exploratory surgery, which is the definitive treatment. The goals are to derotate the stomach, assess gastric viability, remove any necrotic tissue with a partial gastrectomy if needed, perform splenectomy if the spleen is thrombosed or twisted, and permanently secure the stomach with a gastropexy. Failure to perform a gastropexy results in a very high risk of recurrence. Step 7 is intensive post-operative ICU monitoring for the first 72 hours. Continuous ECG monitoring is essential, as ventricular arrhythmias are the most common.
GDV surgery always begins with careful anesthetic induction, and this is only done after the patient has been stabilized with fluids and gastric decompression. Rapid induction is achieved. The dog is immediately intubated, placed on 100% oxygen, and continuous ECG and blood pressure monitoring begins. This stage carries a high risk of dangerous cardiac arrhythmias, particularly during induction and again during stomach derotation. Once the patient is anesthetized, the surgeon performs an exploratory celiotomy through a ventral midline incision. This allows immediate visualization of the abdomen, where the stomach is typically seen as severely distended and most often rotated in a clockwise direction. The spleen is frequently congested, torsed, or displaced along with the stomach.
If the stomach is still distended at this point, additional gastric decompression is performed before any attempt at derotation. This may be accomplished with an orogastric tube or, if necessary, by making a controlled gastrotomy incision to evacuate trapped gas, fluid, and food. This step is essential because it reduces internal pressure and improves safety before rotating the stomach back into place. Gastric derotation is then performed manually in a counterclockwise direction. The surgeon identifies the pylorus, which is typically displaced dorsally and to the left, and carefully rotates the stomach back into its normal anatomic position. This is a critical moment in the procedure, as reperfusion injury and cardiac arrhythmias commonly occur immediately after blood flow is restored.
Once derotation is complete, the stomach is carefully assessed for viability. Healthy tissue appears pink with bleeding edges and improves in color over time, whereas necrotic tissue appears black, green, or gray, is thin, and does not bleed. If necrosis is present, a partial gastrectomy is performed to remove the dead stomach wall. Although this increases surgical risk, it is often life-saving. The spleen is then evaluated for damage. It may be congested, thrombosed, twisted, or ruptured as a result of the volvulus. If the spleen is compromised, a splenectomy is performed to prevent hemorrhage and further systemic complications.
Permanent gastropexy is a mandatory step in every GDV surgery. This procedure permanently attaches the stomach to the right body wall to prevent future twisting. The most commonly used and preferred method is incisional gastropexy, although belt loop, circumcostal, and tube gastropexies may also be used. In incisional gastropexy, a small incision is made in the right gastric antrum and the right body wall, and these two surfaces are sutured together permanently. It is important to note that this does not prevent bloat from occurring again, but it does prevent the deadly twisting that defines GDV. Failure to perform a gastropexy results in an extremely high recurrence rate. After the stomach and spleen are addressed, the abdomen is thoroughly lavaged with warm, sterile saline.
The incision is then closed routinely in 3 layers. First the linea alba, then the subcutaneous tissue, and finally the skin, and a protective bandage is applied. Any delay in surgical correction significantly increases the risk of gastric necrosis, sepsis, disseminated intravascular coagulation, and death. Post-surgically, intensive ICU monitoring is required for at least the first 48 to 72 hours. Continuous ECG monitoring is essential to detect ventricular arrhythmias, which are the most common fatal complication after GDV surgery. Blood pressure is closely monitored, and signs of reperfusion injury are watched carefully. Lidocaine continuous infusion is used if dangerous ventricular arrhythmias occur, and feeding is gradually restarted 12 to 24 hours after surgery.